Good afternoon. Thank you all for joining us today. The topics of today we're going to try to cover will tell us where we believe the healthcare markets were pre-COVID, what has happened in the past 100 days, where we think we are now, and where it is that we believe that we'll be going in the future, and what some of the opportunities and solutions will be for healthcare providers in the market to allow them to either be successful or to achieve their objectives. Today, we have three very knowledgeable participants as our panel, and I'd like to introduce them now. Ken Mann is the Managing Director of SC&H Capital Special Situations Investment Banking Team. In his 26 years in the business, both with Equity Partners HG, and now with SC&H Capital, Ken has been involved in more than 500 successful distressed investment banking engagements across many industries, including healthcare. He has completed hundreds of 363 sales in over 70 different bankruptcy courts around the country. Joining us from Atlanta is Derek Pierce. Derek is a managing director at Healthcare Management Partners, a leading consulting and turnaround firm in the healthcare industry. Derek has more than 20 years of experience in the healthcare industry, having served in several leadership and restructuring positions. He has audited, managed, and consulted with all types of healthcare providers and has served as the CFO in the extremely successful turnarounds of two large multi-state elder care providers. And lastly, Rick LaForge. Rick is a director at i3 Healthcare, a healthcare business consulting firm. Rick has more than 30 years of diversified experience in the healthcare industry, including finance positions in the provider sector, executive positions in healthcare revenue cycle outsourcing companies, and leadership and service delivery positions in several leading healthcare consultancies. In addition to his consulting work, Rick has several years of experience both as a leader in rev cycle outsourcing and denial management companies, as well as having served in finance positions in both not-for-profit and for-profit hospitals, as well as the continuing care retirement community. So with that, gentlemen, I'd like to offer the first question, and that really is there been a particular segment that has been dramatically hit by this COVID environment? And I'd like to maybe ask Rick, your feedback based on the work that you're doing with hospitals around the United States. What are you seeing today?
Well, I think, Chris, it's worth, given the fact that we have lived and been immersed for the last 3 or 4 months in this pandemic environment, I think it's worth kind of going back and saying, where were we before this, so we can really measure where are we now and understand what the impact has been. So I think it's worth to take a minute to say, where were hospitals and how were they performing before the pandemic? What's the baseline? And, most people may or may not realize this, but for the last 20 years, hospitals have been doing pretty well. They've had very healthy, positive operating margins for virtually 20 years. There have been some that have done better. There have been some that have not done so well. But overall, hospitals have been pretty profitable for that period of time and stable. Before COVID, even before the impact, there was some concern about what's going to happen with Medicare and Medicaid cuts, what's going to happen with value-based care transitions, what's going to happen with dish cutbacks and that sort of thing. So the CBO has done some projections, as they usually do, rolling 5-year projections. And already before the pandemic, it was looking as though roughly 40% of the hospitals were going to go from close to a positive to a negative margin during that time, even before the pandemic. So that's kind of the community hospital baseline that we're talking about. One segment that was disproportionately underperforming and really struggling, Jen, if we can move to the next slide, is the rural hospital environment. So you were doing pretty good if you were a community hospital, an academic medical center. If you were a rural hospital, a critical access hospital, if you were a sole provider, you have been struggling for some time. And you can see here, margins have been negative. They've been significantly negative, and they have been increasing for the last several years. And small hospital, rural hospital closures have increased as well. 2019 was a record year with 19 closures. We've had 12 already this year in 2020, and that's just going to become a greater issue now with the pandemic. Now, Derek, I know that's kind of the hospital side. You do a lot of work on the SNF side. Are you seeing something similar there or something different?
Well, we see on the nursing home side, it's kind of an interesting industry in that and we'll talk a little more about the the pandemic's impact, but it is the recipient of a lot of these referrals from the facility. So when someone's coming in to get therapy from the hospital, they're going to come to a rehab or a long-term care hospital, and of course that siphon has now been shut off. But I think the real challenge for us is the other side of the house, which is our long-term residents and those that we have to care for 24/7, these longer lengths of stay. And so as an industry, the nursing home already had its challenges with over 4 million short-term and long-term stay residents in place. We were dealing with a lot of competition in the market, a lot of home care coming and taking the business that we had traditionally enjoyed. And overall, we were lowering lengths of stay. And that coupled with some managed care initiatives that certain states were adopting, slowly adopting, added on top of that a PDPM program that Medicare just started in October. We were really sort of right for the perfect storm of just a lot of things being thrown at the industry. And I say all that, we have still seen transactions, so it's kind of funny that we end up with talking about sort of the fact that there's challenges in this market, but we've seen a lot of transactions. And Ken, I know this is your area of expertise. Despite seeing declining occupancies, like you guys can see on this chart on a use rate, there's still a market out there. So I guess Ken, maybe that's our segue for you, but I'm curious how you see things or saw things prior to us going into this pandemic.
Yeah, thanks, Derek. Frankly, the M&A activity was good. There was a lot of activity and prices were pretty healthy. If you look at these charts, you go back even prior to 2013, hospitals having that long history of profitability and reasons for consolidation and so forth, really driving a lot of M&A activity. And those levels have stayed consistently high, even peaking out in 2015, 2016, even higher than already high volumes. Same with clinics, outpatient services, progressively higher all the way through 2019, and in elderly and disabled care, falling off a little bit, but off of really high deal volumes. The blue part of each of those charts represents private equity transactions, and you can see a lot of private equity dollars were being funneled into those clinics and outpatient services. This is a great graphic from the Polsinelli Troller BK Distress Index, and it shows you the distress level in the healthcare industry. It was very high pre-COVID. The baseline for this is 100, and so this is showing you companies that filed bankruptcy, what was their distress level. The baseline from 2010 was 100, and as you can see, by late 2018, healthcare had climbed to over 500. Right before COVID, it had fallen down to about 233, but that's still 4 times what other industries are experiencing in bankruptcy, somewhere around 58 on this index. And healthcare, really way more distressed coming into COVID. The graphic to the right is probably surprising to a lot of people. It's not just huge cases being filed. The blue part is cases with 1 to 10 million in assets in healthcare that filed bankruptcy during the quarter. And if you include the red, you've got 93% of these cases have assets of less than $50 million in revenue. So that's where we stood pre-COVID.
So guys, let me just ask a question. If there was this much distress that was going on in the market, why were there so many deals that were happening? And what do you think was maybe causing some of that? And was there any issues relative to size, as Ken pointed out, or was it even geographies?
I'll take a stab at that first, Chris. Highly liquid markets, readily available debt financing. So that would drive prices up, and record amounts of dry powder in the private equity world. And then people saw opportunities specifically in the clinics and outpatient area. That's why you saw so much blue on the graph. There was really opportunity there to roll up fragmented industries. With respect to, one more slide back if you can, Jen. So see that dark blue in the middle on those private equity dollars, and you can see they were really pouring into that segment. And then also in the hospitals, because the early levels of distress, there were a fair number that had to sell. And so you saw a lot of sales more, because of distress than because they were trying to cash out at a big number. Interesting question about geography. Yeah, I think the distress is heavily in the Southeast and other states, mostly driven by what states chose not to expand Medicaid. But Derek and Rick, you can chime in on that.
I agree, Ken. I think from the statistics I've seen, there has been a real disproportionate share of these cases showing up in the Southeast. And they are all mapped very closely to those 8 or 10 southern states that chose not to expand Medicaid. And I think I read recently that there was roughly 18 million people that were subject to the COVID virus because of their health conditions and pre-existing conditions that lived in those states that didn't expand Medicaid. And so those folks' inability to access services, I think, is a contributor here as well. But I think that is a major factor on where these have occurred, especially at the size, at the clinic and small business and physician practice level.
So if we now take all the news that we've been hearing and the doom and gloom that's been put out, and there are statistics everywhere, what has changed now as a result of the past 100 days that you're seeing with the clients that you're working with that would really be what the people on the webinar today want to hear about, so that they can learn had they not heard from you? Maybe Ken, you can give us a shot to get started.
Yeah, I'll give you sort of the general investment banker sense, and then I'll let the real experts talk about the healthcare specifics. But usually in a recession, healthcare's revenue drop lags behind GDP, and we saw that in the Great Recession of 08 and 09. But due to the shutdown of the non-essential procedures, obviously here the revenue drop was immediate. It's like flipping a light switch, and it was in fact greater than the drop in gross domestic product. Seen a lot of different numbers, but I think revenues off 18% in healthcare in Q1, certainly going to be much worse in Q2. The American Hospital Association says the 4-month impact will be a loss of $202 billion for American hospitals. And as I look into the next phase a little bit, unemployment drives the loss of insurance, right? We have record unemployment. You're going to see 12.5 million people move away from insurance to Medicaid or to uninsured. And so you're also seeing a payer mix that is significantly less favorable for the providers. Derek, Rick, you can pick it up from there.
I think with what's happening with the state economies, that you're going to see a lot more Medicaid recipients actually coming off the rolls. I think the qualifications are going to be tightened up. I think the work requirements are going to be, people are going to be unable to meet them. And I think in order for the states to be able to balance their budgets, they're going to have to be Medicaid cutbacks. And eventually Some of those are going to impact providers that contribute to this, but also a lot of it's going to contribute to spike in the uninsured.
Yeah. Jen, could you go back one slide for just a second? Just a quick snapshot before you go further is, the level of M&A activity obviously dropped off significantly. This looks at the first 2 months of the quarter, 2019 versus 2020, and hospital transactions dropped off about 73%, clinics 80%, elderly and disabled care a 52% decrease in completed transactions. And all three of us have experienced firsthand the delayed M&A activity in the space. If you guys want to talk about specific cases that you know of that were delayed.
Or even, Ken, let me ask a quick question. Do you expect the decreases to continue? Or do you think that this will turn?
I think it'll turn. I believe there was a period of paralysis where there was no visibility, so much uncertainty, and private equity and providers stopping to say, wait, I've got to tend to my own. I've got to circle the wagons and make sure I'm stable. But we're starting already to come out of that phase.
Interesting. So Rick, you were talking about hospitals and some of the dramatic changes that are happening. And I think even today there was a news release that the university hospitals in Cleveland announced some of the pay cuts even for their clinicians. Given the work that I know you and I both do with academic medical centers, what are you really seeing that's happening that people wouldn't really appreciate or is going on, and what's forcing hospitals to change the way they're operating?
That's a great question, Chris. Can we go back one slide there? So there's a number of changes that people really probably aren't thinking about that are taking place in hospitals right now. There's obviously a big shift out of ambulatory services into telehealth. So there's a big question around, will that remain sustainable going forward? Patients seem to like it. CMS has waived a lot of the rules related to telehealth. So there's a big advancement in telehealth, mobile health, those types of services that will take volumes outside of the hospital. So one of the questions is, what does that mean? What does that mean for our healthcare delivery system? What does it mean for our cost structure? One of the other things is that we're bringing people back to the hospital now. We're reopening, right, in a lot of areas. So people want to come in for their surgeries. They want to come in for the deferred elective services. ED space is a really big one right now because probably on an average hospital, 60% of your non-elective admissions would come through the ED. Well, if we had 100,000 ED visits as a big hospital on an average year, we may only get 50 or 60,000 this year. A combination of people not coming back to the ED, being triaged and sent somewhere else if they're not emergent, and simple workflow issues within the ED. Social distancing practices will continue. New cleaning sterilization practices will continue. We won't have the throughput levels that we've had in the past. So all of those kinds of changes are coming down the line, and then we're all doing this without really any knowledge of what happens next. Will there be a resurgence? Will we be in a position to respond more proactively and more efficiently next time? And when will this next pandemic hit? So all those are considerations that are really changing the fundamental operations of hospitals as they respond to this and as they reopen and begin their recovery.
So I'll highlight the article that I had referenced to you, and I'll just make a note for those of you on the webinar that more than 200, and this was announced this morning, more than 260 hospitals in the US have now furloughed workers as a result of COVID. And now we're starting to see the pay cuts even for the clinicians. And it's remarkable because most people are thinking that the hospitals have been busy and everything that we've been reading, but the reality is that this kink that's occurring now will really start to dramatically affect the whole system. Would you agree?
I would wholeheartedly agree. You know, one of the mergers that did not occur because of this was the big one between a big Michigan and a big Ohio provider that was a $6.1 billion deal. It had received regulatory approval and it was set to close on April 1, and it did not close. It got called off. And the acquiring system prior to that had lost close to $300 million in the first quarter, as I understand, permanently laid off 450 staff and furloughed something like 2,700 folks. So just the impact of that, even though the merger made perfect sense, there was access to capital, it was regulatorily approved, it has been totally canceled right now. And I think all of that is a fallout of what we've been talking about. So just briefly, we all know what the impact has been significant within hospitals, but how significant has it been? This information came out of a monthly hospital flash report that is produced by the folks at Kaufman Hall, and it just gives you an idea of how quickly and how precipitously hospital margins have fallen since the pandemic hit. And now, of course, the question is, when, what happens next? When do people come back? When can we start to see this return? And also, just to kind of give you a historical perspective of how does this compare to what we've seen in the past, I would argue that it's not comparable to anything we've ever seen in the past. And I know these graphs are small and they look a little busy, but here's the bottom line. For the graph on the left, that's the average operating EBITDA for hospitals in different regions. And if you are operating better than budget but less than prior year, you're in the right bottom quadrant. If you're beating your budget this year and you're beating last year's performance, you're in upper right. The lower left-hand quadrant, and you can see how large the percentages are. This tells you by region how poorly the hospital EBITDA margins are doing and how much they've been impacted by the pandemic. And you can see it doesn't discriminate by region. The graph on the right shows you the same thing, but only by bed size and bed cohort. So you can see that the impact has been unprecedented from anything we've ever seen in the past, and it's been pervasive and nobody has been immune from it. And also volumes. Obviously, we would expect to see similar trends in volumes and a similar impact. This is a snapshot very similar to the last one. Hospitals live and breathe off ED visits, off adjusted patient days, and off OR minutes. And you can see here the same thing by region. No matter how you look at it, volumes are down significantly across the board, and the impact is pervasive. So we've gone from a stable kind of earnings environment where there was some stability and some basis for moving to value-based care and some other models, now to a situation where we've never been before. And the question is, how do we get back? How fast does it take? And will we ever get back to the point that we were? Or do we need to be looking and thinking about something different in terms of the new normal? Derek, what's going on the skilled nursing side?
Well, we, as we talked earlier, we have seen that admission issue replicated on the Medicare, and CMS has made some changes, good changes to help with that regard in flipping Medicare to a status without having to have a Medicare or a hospitalization. So still, we've seen that slow down on the admission side, but back to the other side of the house of the facility is caring for these these residents 24/7, and essentially putting the buildings on lockdown while certain folks are coming in, caregivers are coming in, loved ones cannot. And so we're seeing it's just, I know this is repeating a lot of the news that you all have read, but it's been just a devastating impact. 40% of the the deaths that have come about, COVID-related deaths, are in the nursing homes. And so what we're dealing with is highly infectious disease placed upon an unprepared industry, and that's no other way to say it. And we are trying to catch up. We've got stressed and overworked caregivers, and we've got states doing their best to put in PPE regulations and oversight to help, but also make sure that that everyone's doing the right thing. I'm receiver over 4 nursing homes in Texas, and those buildings all had mandatory testing, and we are getting those results back, just waiting to know where we need to put our efforts. We're doing the lockdowns, we're doing all the things we're supposed to be doing, but what wing are we going to put these folks on for the COVID wing, if you will? So that is kind of where we are. That coupled with what we talked about earlier, with the fact that we've got lower lengths of stay and payment rates that are lower on the Medicaid side, that we're just really challenged.
So guys, let's talk about challenges for a minute, and we're going to have them both in the short term and the long term. And so collectively for these next couple slides, I'd like you all to be kind of giving us some feedback as to what you see as short and long term, because the interrelationship of the hospitals with the nursing homes, with the SNFs, and with the capital markets are what really are going to find the solutions that we can ultimately talk about. But let's make sure that we've really outlined the challenges that face us. So I don't know, Ken, maybe you could kick it off.
Yeah, and I'll stick, Chris, just to the kind of cash issues here. And this is looking at the first stage, if you will, the shortest term stuff. A lot of this we're in fact already through. Then we'll look at the near term and then the longer term. So in this first stage where you're really limited to essential procedures, everyone is extremely cash constrained. So they're deferring everything they can: rent, mortgages, trying to get extended payment terms on with suppliers. They're deferring payroll taxes. Remember, there's personal liability there. Trying to get government aid through the CARES Act. What we've heard from our client base is that trade payables just haven't been that flexible. They're making demands for payment now. And across all other industries, you're seeing landlords give almost automatic deferrals. Not so in the healthcare space. They've been a little less flexible. As you know, a lot of the real estate in these organizations are owned by REITs, and they are somewhat limited in what they can do just due to the regulations and answering to their shareholders. But the suppliers is a surprising one to me. They're being tough and even asking for payment in advance. And Derek and Rick, I know you see that when you're in as an operator, if you want to talk about that.
Yeah, I have seen and heard that too with through some of the GPOs for the hospitals, that the vendors, of course, like everybody, have tried to respond proactively to make sure that the hospitals had the PPE and the supplies they needed during the surge and the specialty products that they needed, and kind of set aside payment terms, if you would, because everybody was rallying around the patient. And now that perhaps the pandemic is beginning to subside and people are coming back for their elective procedures and the demand for supplies is ramping up again, I think some of the suppliers are beginning to say, hey, wait a minute, we need to come to some arrangement here, because we're way behind on our payments, and we're willing to work with you, but we've got to come to some sort of agreement going forward. And even if you are a hospital that was fortunate enough to get advanced payments or accelerated payments from Medicare or some other supplemental payments, especially if they are like the advanced payments and those sorts of supplemental funds that are really in the form of a loan that you're going to be paying back down the One of my big concerns about hospitals is it's great that we're reopening. It's great we're doing elective services again. People are coming back to our ED, but we still have to go through the process of billing and collecting for those services. So regardless of what your patient mix is or how favorable or unfavorable it is, you're still talking about probably another 60 to 120 days of working capital needs that have to be met just to sustain the people coming back and the volumes that are coming back to your hospital. And if you put on the repayment and the terms of the CMS advances and all the other deferrals that you have been granted, I think we're going to be in a cash management situation that could be pretty severe for a lot of hospitals for several months to come until this gets sorted out.
So Rick, take that number of 60 to 120 days as the challenge. For the listeners, what is a normal cash days on hand for a hospital, just to show and benchmark what that really means relative to real numbers for the average hospital?
You know, I would say it's hard to define the average hospital, obviously, but for the hospitals that we typically work with that aren't distressed, we're used to seeing, 100 to 150 or 180 days cash on hand many times. And I think what we're seeing right now are cases where it's much less than that. So we're bringing back patients, we're bringing back furloughed staff, we're reordering supplies, we're spending a lot more time in expense and sterilizing and cleaning our facilities to make sure that from infection control standpoint, we're in a good shape. But the cash is not flowing in to cover that just yet.
So Derek, what are we seeing on the SNF side and the nursing home side? Is it the same effect?
It is. Now, I in addition to being in that space, I work with assisted living facilities, and I'm typically in those that are in some form of distress, whether it's receivership or bankruptcy or the CRO. So I would love to have 100 days of cash on hand. I wouldn't know what to do with myself. And in fact, over the last couple of weeks, it's been that PPE funding, the CARES Act 1, CARES Act 2, all that money coming in. And it's obviously for everyone everyone knows, vendors included, that this has come about, and it has an intended use. It's supposed to be used for that, but people like the word fungible when they talk about cash, and you're using this to make payroll, but now you freed your other cash up to be able to you can keep me current on my pharmacy supplies or PPE or what have you.
Yeah, and at this stage where you're in this reopening, it looks good. Funds are coming in, but really managing that cash is critical because now you have to start paying back. You got to pay the piper. You pulled some revenue forward and you pushed some expenses out, but you really haven't changed the ultimate working capital in a positive way. Chris, unless you have another question there, there you go. So then you get to the next stage, I guess we'll call it the new normal, because I don't know if it's really normal. What we do know is regulations will continue to change and shift, and you're going to have to show how you spent that money. I don't know how it's going to work out, but from my perspective in the M&A world, there's a whole set of new risks that have to be evaluated, right? You moved up revenue with advance payments, and you pushed off some things with tax deferments, but what's got to be paid back, and that's particularly important in an M&A transaction. I think you'll see audits so that we can prove where the money was spent and is it forgivable or not, and as I said, reconcile your advances. I think you're going to see a lot of covenant default if you haven't already, for all the reasons we just stated. That cash flow hole in between is going to create a lot of covenant defaults with lenders. And then the big unknown, what happens in the fall? Do we have another wave? What happens to revenue and cash flow and so forth at that stage of the game? So I don't know how you guys see the new normal, but from a cash perspective as an M&A advisor, it's a little scary to me.
So let's now go to the real juxt of all this, and that is, what are we going to do to get out of this? What is it that operators, or for many of the advisors that are on the call today, can be thinking about and make available to their clients? Because there are going to be a lot of clients in need, whether it's hospitals, assisted living, SNFs, nursing homes, et cetera. So what are the options going to be for some of these distressed healthcare companies? And maybe, Ken, you can help us kick that off as the next slide.
Yeah, I guess you can think of me as the emergency room doc, and I see those cases that are nearing death and need something to happen quickly. So these are options that you would use in those cases. And the immediate options, obviously, the CARES Act funding, utilizing your line of credit. There's been tons of press about how every hospital ran out and grabbed available line of credit. The deferrals we talked about, gaining forbearance from your lender, saying, hey, I know we're going to be in covenant default, but let's have a 3-month grace period. And if you're really in crisis and just can't hold the creditors at bay, you've got to file bankruptcy. A little bit longer term, how do you really fix the problem and the balance sheet? You may have to restructure your debt with your lenders. You may have to look at bankruptcy, not so much in the crisis mode, but as a way to restructure for the longer term. I think a lot of healthcare businesses have accumulated real estate over the years through acquisitions. They might look to sale leaseback of the real estate, potentially obtain new financing. Chris, you and I have spoken to several healthcare lenders in the last few days that say the bank is open, we will lend money. Probably could sell some non-core assets. You know, lots of Rick's hospital clients probably should be selling the SNFs that Derek's working on. And then, of course, there's the option of sale or merger of the entire organization. The restructuring and forbearance require a plan. They require visibility. And so I throw it out to you guys. I don't know how you get that right now. You don't know what money's going to come in from CARES. You don't know what your increased costs of operations are. And those are the kinds of things that you guys focus on and try to work with.
Well, Ken, if you're the ED person, I've always tried to not have to refer my clients to you, because that's a last resort thing. But you know, it's interesting. It's interesting that you mentioned the restructuring, because I don't see this that often. But there is a hospital very close to me in North Carolina right now that just filed Chapter 11 to restructure their debt as a last option. They were looking for a successor organization, a partner, and we're in discussions and just couldn't wait it out. They were making progress. COVID tanked I wouldn't even call it negotiations. It was basically at an exploration level. And they are a sole community provider, very small hospital, a community of about 100,000 people who have no other healthcare option. So they have just embarked along this Chapter 11 restructuring path along your long-term solutions there to see what they can do to preserve their future for their local community.
So if we start to look at it in segments, Derek, what are some of the strategies that SNFs are going to really have to think about that you're advising clients on right now?
I think first and foremost, it's infection control. I mean, it's bringing in more RNs into the building, getting workflows, protocols set to prevent the spread if it is in the building, and preventing it from coming in if it's not. So it you know, whether that's throwing additional people, working with we actually engage clinical professionals to come in on any of our engagements. And first and foremost, it's an assessment, and you know, let's look at QAPI and let's see how well they're doing it on their own. Let's tweak it if it needs to be tweaked, or let's start over. But I think that is where we are on the SNFs. I wrote down telehealth strategy. It's no different than the hospital. How can we utilize technology, which this has not been historically a big area of focus for the nursing homes. They are typically lower margins and low reinvestment when you're looking at a hospital. So it is going to be a new day. I would probably also add on the SNF side, go hug a hospital, go partner with one. Just, years ago in Syracuse, we did something, and it keeps resonating in the back of my head about this complex care initiative where, lengths of stay were a problem at the hospital. We had a lack of competency to take some of those discharges. Well, those nurses from the hospital started coming over and training our nurses, and it really became a great initiative for them. You could look at it on a reduction of medical DRGs and those surgical DRGs. They had room for them, and we upped our acuity game. And I think that in a round way is where we're heading for these nursing homes. Another uptick on our ability to deal with acute patients.
Rick, what are you seeing on the hospital side?
I think for the hospital side, the overriding message is just get back to basics. If you are one of those hospitals that strategically in the past has thought it's really important to control the continuum of care and have your SNF and have your home health agency and have even your assisted living facility or your retirement community to be able to provide all those services, is it time to rethink that and say, are these really my core businesses? They're not so much part of the new value-based care and some of the other models we're looking at that hospitals really need to focus on. There are other organizations that are more expert in managing and developing those types of facilities. So is it time to consider divesting those and using that capital to focus on your core business? And then I think the second component is, what is your core business as a hospital? Chris, you and I mean, we know that we're working on a deal right now with a hospital and a operations partner who have agreed to build a new hospital together, a replacement hospital. And we're talking about taking an existing 480-bed teaching hospital that does everything and replacing it with a hospital of perhaps 250 beds that focuses on 5 core service lines and take those other services and provide them in other modalities or other hospitals. So in my days as being a implementation person in restructuring and margin management with hospitals, I'd have lots of conversations in the C-suite where the real plan, what you really needed to do was tear it down and rebuild it more efficiently and focus on what services you can provide and make a margin at and divesting yourselves or minimizing those that you're not going to do well on. And you don't have to necessarily provide it. Most CEOs would say that's a great plan, and I agree with you, but I can't lay off 2,000 people, and I can't stop all these services, and I can't take a time to rebuild everything. I can't take a $100 million haircut. Well, guess what? A lot of you have already. You've already furloughed a lot of folks. You've got physicians that are misaligned. You've taken the hospital down to the studs, basically. So take a breath, take a minute, and really use the analytics and the data to find out where your real strengths are, what your core business is, and focus on the recovery, rebuilding those areas. And don't just rush in to get the volume back to be where you were before, but take a breath and a moment to think about, is that the best approach, or should we be more targeted and more strategic around how we build our recovery?
Yeah, and I think that what you and I have both seen on some of the work that we're doing is the customers are changing as well in the way that they interact with their healthcare providers. So you're right, it's a great time if you have access to the data, and there's all kinds of data that's out in the market. We know many of those sources, and if anybody needs referrals, we're happy to tell you about the ones that we use and that we see, but it will really give you an idea of your markets, what's going on, and how you can best be more efficient and effective in those places.
Right.
So Ken, I'm sorry, go ahead, Rick.
I was just gonna say, don't necessarily rebuilding your own image, rebuilding your patient's image.
Correct. Funny how we have to focus on the customer again. I think we've heard that in the business world a few times. So Ken, talk a little bit about the interaction with lenders. What's going on with that right now, and how are lenders looking at this?
Yeah, I love this first point. I think this was Derek's, which is, what's your tolerance for knowing the truth? Do you want to stick your head in the sand and look the other way, or do you really want to know how bad it is, and are you prepared to take action? So, I think lenders have to have some patience here at the start, and they have to, they have to recognize the difference between what was pre-COVID distress and what is COVID-related distress. And if it's COVID-related, you really need to consider all your options to stay patient. You may need to repaper the deal to create a future financial picture that's workable. But if it was distressed before COVID, you have to look at it a different way and think about making this tough decisions as to who's going to live and who's going to die. Because if it was distressed pre-COVID, it's in real trouble now. You have to evaluate cutting your losses and moving on from those. And of course, everybody on this webinar likes that last bullet. I don't know who put it there, but thanks. Hire a consultant, find a restructuring officer. You got to look at receivership, look at all your options, unless you're very comfortable with the management.
So as we're about 10 minutes out, let's go to some of the issues that might involve the unfortunate aspects of bankruptcy or having to go to M&A. And again, we offer, if you've got questions, please send them in, and we'll try our best in these last minutes of the webinar to answer them. But Ken, maybe you can kick us off with this.
Yeah, I don't want to get too technical here, but a lot of these transactions are going to happen in bankruptcy courts, and historically, the provider agreements and residency slots have been viewed as executory contracts. They have to be assumed and assigned pursuant to Section 365 of the Bankruptcy Code, and that can cause delays in closing. It creates a contingency in the bid process where bidders have to bid contingent to that. And there's tremendous uncertainty in negotiating with the government. The other thing is you can have some huge cure costs related to these contracts. So a buyer, to assume it, would have to pay off all of that cure cost. And so it makes it less economically viable to do a sale transaction. You also would get all kinds of liability if you were to assume. So interestingly, there's been a few cases, Jen, on the next slide, that challenge that treat it more like a license or what we call a statutory entitlement, and say it's just like any other asset. You can sell that asset free and clear of the liabilities. You don't have to cure it. You don't have to assume the successor liability. And the two big cases you're hearing about are the Verity decision, which was in California, and the Hanneman decision in Delaware, which said you could sell residency slots and you could sell provider agreements free and clear. Hanneman it has been appealed, and I think that the closing did not occur because of that appeal. We've seen in the Middle District of Florida similar rulings that allow you to just sell it without paying, whatever quality assurance fees, overpayments, whatever, not having to pay those back.
So Rick, I think it might be pertinent here for our listeners, for many that may not be aware, talk a little bit about residency slots and the fact that these don't just come up and they can be recreated, but these are basically permanent as issued by CMS.
Yeah, not only are they permanent, they are restricted and highly valued by those who can acquire them. And as you know, Chris, our client that I mentioned earlier, I believe has 240 approved IME slots. So those are basically your CMS authorizations to train up to 240 residents in your programs at your hospital through your College of Medicine that are funded, not completely funded, but much of the teaching and training costs for those residents is reimbursed through CMS according to these seats, these residency slots. So they are highly valued. The particular client that Chris and I are working with have a College of Medicine, and even in their more challenging times when their volume was down and they weren't doing so well financially, worked very hard to protect their slots to demonstrate that they had enough volume and enough business to continue to be effective trainers and teachers of the residents. These are not easy to come by. They are usually capped. So if you were a new medical school looking to establish a new residency program, there may not be residency slots available to you until some other ones are recouped or surrendered. So that's how valuable they are. And the question is, are those slots, because they are granted and monitored and funded by CMS, really the property of CMS, or do they belong to the hospital itself? And if it belongs to the hospital, do they have the right to sell it like any other asset on their books? So we're, to my knowledge, there is not another case around CMS slots similar to the Hahnemann case. So we are looking at that very closely to see what the appellate court says, and I can guarantee you that CMS will fight this in the courts as far as they can, because it is not in their best interest to have residency slots deemed as an asset that can be traded in the open market and not regulated by CMS.
So that'll be an interesting case to watch. So let me throw out a question that's come from somebody listening in, and I'm going to tie actually two of these together. What are we seeing as the future of value-based reimbursement to providers, given the movement to risk mitigation and population health? And then as a corollary to that, what do you think will happen with behavioral health? Because there had been some compression of rates previously, but from all things that we're reading, these are issues that are accentuating themselves in these past 100 days. Would any of you like to take a crack at those as an answer? Postulate?
Postulate? I'll take a crack at the first one, Chris. I've talked to a few people in different aspects of this whole value-based care movement, people that are deeply involved with ACOs, physicians, people who are involved in the data side of the coding and all the data that is used for risk adjustments. And I think, my opinion, my postulation is that in the short term, we are going to see basically a pause or a freeze in the kind of migration to value-based payment and population health management. I think it's still the policy of choice. I think most people still agree that it is a viable solution to the issues that we have in our system. CMS, I think, has signaled that it is their intent to basically freeze the process, ensure that providers who are participating in these programs now are not disproportionately harmed because of the COVID crisis that they've had to respond to. So I think in some cases with new programs that are coming on board that they plan to implement, they have stretched out the implementation times. For some existing programs, they have stretched out and delayed reporting requirements to give people time to respond. And in many of the existing payment arrangements, they are fundamentally saying, we are not going to hold you responsible for whatever's happening in your market. We are not going to penalize you for COVID. We're also not going to reward you or bonus you if you've avoided a COVID type of situation. So we're going to try to make everybody whole, no penalties, no bonuses for the most part. But I think going forward, the intent is once we really understand, because these programs are all data driven, right? They're all data driven, and all this anomalous COVID data is in there that would foul up a risk adjustment. Once we understand the context of all of that and how to move forward with clean data or normalized data, I think we continue on the same path and they pick up pace again. But I'm predicting the next 6 months to 12 months will kind of sit in place and idle. And then once we get our arms around the data and what it means and how programs need to be restructured, then we'll continue to move forward, possibly at an even more accelerated pace.
Derek, have you seen anything related to that on the senior living aspect of healthcare?
There's been numerous initiatives for that, to being kind of the recipient of those lives and keeping them out of the hospital, those readmission rates that everyone has heard about over the years. And obviously we're, as the nursing home, trying to keep that as low as possible. But I agree with Rick. Everything is kind of stayed, if you will, until we get through and we get our bearings on, living with this new reality. I think we've got some other housekeeping items to deal with before we come back to some of these initiatives.
Yeah, and I guess I'll answer part of my own question is, Ken, you and I talk to private equity groups all day, every day. One of the areas, if you believe the follow the money vernacular, many private equity groups are very interested right now in behavioral health investments. And I'm going to have to assume that their theses are being based on not only the fact that they could potentially be more efficient and that the patient population is going to grow, but that those reimbursements are going to come back. I can't imagine that there's the doubling down of money in that particular area if there wasn't that thesis that was going to happen. So as we have just a couple minutes left, closing remarks from any of you. I'll start with Ken and we'll work our way across the compendium.
Yeah, I guess I'd just say, there is a brighter day ahead, and there's plenty of liquidity. There are answers for everyone. It's just making sure that you know really where you are and what the cause of your distress is, and communicate. Make sure your lender knows exactly what's going on and what your plan is. Derek?
I think my takeaway is focus on what you do best. The clinicians, hug a clinician. The COVID pay that we talk about in the building, it's real. I mean, they're dealing with things every day, and support them with cash and with that COVID combat pay, but also, make them better at what they do. Reinvest in them with these tools, these copy programs, and with technology, and let's get to it with some of this. Some of this has been, with some of the buildings I'm working with, has never been done. Wi-Fi doesn't even exist at the end of hall number 200. Let's get on with some of this stuff. So this is the time that it has to be done.
Rick, you get to close it out. We have about 30 seconds.
Okay. Well, first of all, I agree with what Ken said about being proactive, talking to your lenders about your situation. And I think Derek's exactly right too, is get back to basics. So, the only thing I would add to that is, especially if you're a hospital out there, is take a breath, really understand what you want to do. And I think the focus really in the next 60 to 180 days to really almost close to a year is not so much margin management, it's cash management. So, focus on that, get back to basics. If you're in a business, it's not one of your basics, look to get out of it or divest. And as traumatic as this process has been and this pandemic has been, it's a larger opportunity than it has been, I think, a burden in the longer term. So take a breath, take a fresh look, and take advantage of the opportunity.
So with that, I thank all of you for joining us today. If we can answer any other questions, emails are here on the screen, and we welcome the opportunity to connect with you if we can be of help. Gentlemen, thank you for your time. For those of you that listened in, thank you for participating, and may you all have a great and very safe day. Thank you.
Thanks, everybody.